ago about this, and I was very excited about the idea. And not that I want to do every Wednesday a session, but I think we also need to see some new people in the picture. And we also need to see some professionals, health professionals from around the world. So it's very exciting to be the first one to start the whole series. My name is Els Brouwer, for those who do not know me. I have been working for Medi for almost 10 years in product management, sales international, and a lot in the educational side of things. So I've been around the world. I know most of you, but for the new people, welcome. Nowadays, I am consultant for Medi. I have my independent consultancy business since the 1st of September of this year. And I'm glad to still do things for this wonderful company. Today, we're going to talk about lipedema. And lipedema is something that is still quite new to the world. I would say if you compare it to other diagnostics, it's still very confusing for a lot of people. And there's a lot of different opinions about it. And I think that's why it's important to every now and again update the consensus paper we have supported as Medi. And today I will not tell a lot of new things, but for those who are new, probably it's all interesting. I saw that the Scandinavian colleagues are there too. They have seen most of the slides, I think, because it's a combination of slides from Robert Damstra, from Ad Hendricks, from Annemieke Fleming, and myself, because we still work together as a teaching team for the Dutch Paramedic Institute. And we have just recently traveled to Scandinavia in between the pandemic, which was unique. And I'm glad we did it. It was very good. So welcome. And we're gonna start. So we're gonna do the update. And of course, we're gonna talk about compression in lipedema. But first, I want to take you through this whole consensus paper and see what is new or what has changed or what is still the same. I think the statement that we can make right now is something that comes from the 3rd European Lipedema Forum during the ILF conference in November or October. It was already, I think, no, November, in Copenhagen, which was very good to be all together in the world of lymphedema again. And Tobias Birch held a very good speech in the name of the International Lipedema Framework that we have to now state that lipedema is not an edema problem. And that's difficult for some countries to handle that because, that's how they have been taught. It has been there forever. It has been connected to the world lymphedema, but now we're stating that it's not an edema problem. And I will try and explain that a little bit. First of all, it's a world where we don't know much yet. Regarding the epidemiology, there are no verified data from major studies. That's a problem itself. In the light of the widespread uncertainty regarding diagnosis, it can be assumed that there is a high number of unreported cases. I would say that's for sure. Because of the lack of evidence, there will be sometimes a problem in getting things reimbursed in countries, but it's also sometimes that you will get diagnosis done by people who don't know anything about the disease. And that's becoming a problem every now and again. The other problem is that we confuse it often with obesity. If we look at this paper, we have all seen it, I think, by now. If you're interested, this paper is also available via Medi. The consensus document has been printed. I don't know how many copies we have left, but please ask Valerie, Nora, or David for a new copy if you need one. This is the new structure, and this is what the guidelines nowadays say about the diagnostic approach. Because diagnostics are often not done in lipedema. So what do you get? You get a patient goes to the GP and sees an unusual shape of the body and says, oh, you must have lipedema. Then it's often not the case because it's obesity or obesity-related diseases, and the patient is thinking that he has a new disease. And this is how we create illness belief, and that's not the idea of treating patients in this day and age. So the consensus document is quite well accepted. I think now in 15 countries around Europe, we're trying to find more and more countries who want to participate. So also if you are not in those countries participating in this document, please let me know. I'm since a few months also a member, because I'm now chair of the Dutch Physiotherapy Association, where it's important to represent the group of therapists in the Netherlands as well. So I can hand the names or the clinics that can do diagnostics to Tobias Birch from the Vilde Clinic. He's the initiator. By now, I think the group is as large as 25 health professionals, and that's doctors, nurses, physiotherapists, and psychologists. A very interesting group of people who are trying to create a paper and consensus paper, but also guidelines in the future of what we should do when a patient has lipedema, and is it lipedema. So first, it is important to find out whether it is lipedema. So we will look at the edema component. In the basics, there is no edema, and that's why the name is actually wrong. If you look at the classic lipedema patient, there is no edema whatsoever. So they came up with a diagnostic workup. And first of all, you have to do the normal riddle, which is the anamnesis, the physical examination, BMI, which is discussable, of course, because in lipedema or obesity patients, the BMI is not the most valuable outcome. But belly circumference, volume of the legs, and diplex of the legs for the scanning the venous system is important. Look at the tissues and take some blood samples. And on the other side, we want to have a view on the physical capacity, muscle strength, because we know now that obese patients have a higher muscle strength than lipedema patients. This study is still ongoing in Drachten, where Robert Damster is active. José Smenge is doing that study, and that's interesting to see. Pain scores, we know a lot more now about the influence of pain in lipedema. Fatigue questionnaires, it's spelled wrong, but it's all about quality of life questionnaires, where pain is part of, because often, I think in 95% of the patient population, you hear them talk about pain. Then dieting and working out and all daily activities are also important to find the right treatment or the right lifestyle for the lipedema patients. So it has to be an interdisciplinary treatment program. I wanted to show part of the movie of Tobias Birch, where he explains why things should change and why edema should drop out of lipedema. But it's technically very difficult to switch now to internet and to show you a part of that movie. That's why I have put down the code. If you use this Vimeo code, that's our own recording that we done during Lymphology 365. And it's a medi movie about the consensus document on lipedema and now. In those days, that was last year, I asked him, can you please tell us what we're going to do with this paper and how should things change? In that film, you see, or recording, you see a part where they show the lymphatics of lymphedema patients, of a healthy persons, and of lipedema patients. And if you look at that movie, then you see that the lymphatics of a lipedema patient and a healthy patient, of healthy person, is exactly the same. If you look at the lymphatics in a lymphedema patient, you see an enormous difference. So study it, have a look at it. The whole story is interesting. You will recognize my slides as well in there, because we're all working together on creating one guideline. It's very interesting, and that's why edema has to go in many cases, because there is no edema. So what do we say about fat distribution? It's one of the biggest symptoms. It's disproportional fat distribution, as we know now. Everybody knows, I think. And pain complaints they play an important role. But where does the pain come from? more and more research is done on pain in lipedema. We also know that the obesity rate is very high. So almost 80% of the patients with lipedema have obesity. And that's, of course, not a good starting point. Thank you. And I can hear. Can you shut down the sound? Thank you. So obesity is the starting problem already, because you cannot really diagnose lipedema if there's still a lot of obesity present. And what happens, we know now in obesity, is that the leptin, and the definition of leptin is that it's a protein produced by fat cells that is a hormone kind of thing, and that's acting mainly in the regulation of appetite and fat storage. So this leptin plays an important role in lipedema. But again, confused with obesity, it becomes a problem. Then we have inflammation. If you have obesity and you have a raised leptin level, then inflammation is automatically a symptom that we see. And inflammation leads to pain and leads to edema. So if there is an edema component, then it's not due to the distribution of fat, which is not intact, then it's due to the obesity. So we cannot use the name lipolymphedema anymore in the future, because simply it's not connected. If the obesity goes away, the edema also disappears, and so usually the inflammation goes away and you have a healthy body again. So it's quite complicated. And the older you get, the more leptin resistant you are. On the right, you see a very difficult schedule, but this is the story around it, and it needs to be investigated more and more what the role is that causes inflammation and pain. That has to do with the different skin buildup of women and men. I think we all know it, because it's not only in lipedema. If you look at females and males in general in life, we see that females often develop what we call orange peel skin, orange skin, and men have a different buildup of fat fibers. So they have more vertical fat fibers. And that's, it doesn't look like an orange peel skin, or like the female, as you see on the right side, which is really a collection of little bags. Sometimes you can even feel it if you have a little bit of an older tissue, like I have by now. Then you can feel some of the little fat balls in your arms or even in your upper legs. Unfortunately, that's the fate of us women who have to endure that, and lipedema patients have that even more. So it's an extreme buildup of all these little fat bags. That sounds not so nice, but that's the easy way to say it. An example, if you look at this is a severe form of orange peel skin, and on the photos on the left and the right hand side, you can see that all the white is buildup of fat. So that's what it looks like. And in most cases, there is no edema in between that. But if there is an inflammation due to the increase of leptin, then you will see some fluid in between the fat cells. But that's not the actual lipedema. Going to number 3, which becomes more and more an issue in lipedema, is pain. And pain is also related to neuropathy, they say. That still has to be investigated more into detail, but if you come to pain, it's very difficult to measure, because every patient has a different pain experience or different pain level, but the inflammation of the sympathetic sensory nerves plays an important role, and that could explain the pain. Again, a very difficult slide where a doctor could maybe explain it better than I do. So we have an advanced training maybe later in the year with one of the doctors who can explain this better than I can. But looking at Professor Lorimer Moseley, who is very big in the US, He wrote a book, and in Australia actually, he is talking about a lot of skin sensitivity pain in lipedema. And if you read his book, which is in several languages, then you can see it's all about two types of pain. That's the nociceptive pain, that means that it's damage to the skin tissue, or there's neuropathic pain. And neuropathic pain, that's what we're talking about in neuropathy, that's the damage of the nerve system. And then we often talk about central sensitization in lipedema, which is an increased, overly vigilant response of the central nervous system in the response to the sensory information from the body, due to the prolonged exposure to high stress levels and prolonged activity of the sympathetic nerve system. It's the action mode. And as well as reduced activity of the parasympathetic system, we have a reparation mode. Lipedema patients often have a long period of stress because they have a negative self-image. They have a lot of stress because they've been bullied. If they even have morbid obesity, and I've told you this many times before, but it's something to keep in mind, is that they have then a traumatic experience in their life. And that's very difficult. So pain can be caused by several reasons. This is from Tobias Birch, an overview about causes of pain. And the hormones play an important role as well as the adipokines. And the adipokines go up, or the adipokines, whatever you want to pronounce it, and which cause a low grade of inflammation and hypopoxemia. And hypopoxemia is the problem, together with the low-grade inflammation, that cause also pain. And this has been documented in the Journal of Wound Care. It's also a consensus document that was published in November 2020. And for those who do not know what adipokines are, or adipokines, they are, amongst others, leptin, as I just explained, adiponectin, and the MCP1 egg white protein. You can look it up if you want to get more insights in these type of issues. And hypopoxemia is a low oxygen level in the arteries. And that's something we have to deal with anyway as a compression company, because the arteries have to be compressed. So another slide, similar slide, is, but then he added that part that I just mentioned. If lipedema have a long period of stress, it's very damaging, and that's caused by tension, chronic stress, and depression, and all those three cause pain. Now we're talking about lipedema, but if you would look back in the last 2 years on students, on people who have not been socially active due to the pandemic, you will see also a lot of pain complaints increasing due to these three factors, which have played an enormous role in the pandemic. And still, we're not over it yet. So we will see in more depressions in general, not only in lipedema patients, but in a lot of patient groups. There is some publications on pain which can help you if you have to promote compression therapy, and pain is one of the factors you want to make better or want to decrease. It was done in 30 healthy volunteers. That's always a little bit tricky. Personally, I would like to see more studies with sick people or ill people. But often they're using these healthy volunteers because they cannot get any other. They were exposed 30 seconds to 47 degrees Celsius and 15 seconds to 300 kilopascal pressure. And the outcome was very much in favor of the compression group. It was one group who had no compression, and the other group had stockings. So a very interesting small study, but going in towards the right direction, where we can use scientific evidence to promote compression therapy, not only in lipedema, but also in other pain syndromes. Then for bruising, in many books, articles, we read that bruising is one of the biggest symptoms in lipedema. Also, this is a myth, Because if you look at the outcome of some studies and also of Tobias Birch's experience, then you see that bruising is just a minor symptom in lipedema. There's other people who have bruises too, and they don't have lipedema. So that's something I think that's because the world of lipedema is so unknown, we have come up with a lot of these myths. But it's good to find out now that it's not only found in lipedema, especially in lipedema. So we can say that it's a minor problem. Obesity. Obesity is a bigger problem, and it's a very important additional aspect. I mentioned it already. Obesity plays an important role, being overweight already, and so that has a negative influence if a patient would have lipedema. There is a lot going on in the world, but we all know now, and that's not only for lipedema, but also for us, a healthy lifestyle takes care of weight loss in lipedema patients. And this was a call for action and a very interesting paper, and you can find it on the internet, so everything that you see here is public. And it's true, a call for action. You know, we need to not focus only on liposuction, but how can we get those lipedema patients moving, wear compression in the right way, and what is needed to find the right solution worldwide. I put two pictures in here of Barbara Boots. She's a Dutch patient who has helped Medi over the years, many times in educational sessions. Also last week when I did a similar session in the Netherlands, she was present online, and she has lost now 50 kilos just by a keto diet, which I will explain a little bit later, but also by doing exercise. So it's not only a healthy lifestyle and not exercising. She had to do a hell of a lot of work to lose those 50 kilos. In the end, it will be interesting to see whether Barbara really has lipedema, because she was already, as a child, very obese. Her mother always teased her more or less that she had obesity. So a lot of psychological issues from the past. At a certain stage, she got the diagnosis lipedema, and that was for her the reason to stay as big as she was, more or less, because her mother accepted that she had an illness. So the illness belief was created, in this case, towards the parent who has always bullied her child over the younger years, and that's damaging for life, some psychologists say. But now she has picked up, she has very good support, also from her husband, of course, but she's doing a lot of exercise, she's eating in a different way, and this is the result. Later on, we will see another picture of Barbara where you can see the difference. The last one in the new house of diagnostic approach is the psychological issues. As I said with Barbara, that's in most of the cases where patients have lipedema in combination with obesity, that it's a huge problem. A lot of publications about this. One of them was investigated in this paper from Springer, the publisher, and it was done by Jeroen Romein, and they explored the patient's characteristics and quality of life. And it concerned lipedema patients. And the outcome of this study showed that the diagnosis was mostly made by a dermatologist after visiting a mean of 2.8 doctors. So on average, lipedema patients go to 2.8 doctors to find an answer. And that's already causing a lot of confusion. In the meantime, from onset until diagnosis, of the mean average age was 18 years old. Quality of life was significantly lower than the average Dutch female. And in conclusion, the lipedema patients often have severe complaints and experience lower quality of life regarding physical, emotional, psychological, and social functioning. So it's much more than just putting a stocking around it or a circuit or exercising. You need to address the psychological side. And I think many books have now stated that, or many articles, because many books are not available right now. And additionally, we see a lot of comorbidities, and that have a large impact on the quality of life, which makes sense. So within that consensus document, we have also now the therapeutic approach house, I would say. And in that therapeutic approach, many things have left the building, I would say. And there's now some 5 pilots over that can be used in the treatment for lipedema. And one of the most important ones is physio or movement therapy, which is nothing new. There's many, if you look at all the literature that is available around lipedema, or like on exercising in case of obesity, then you see that the most important ones are reducing inflammation, also in combination with compression, and that's also proven in cancer patients and diabetes patients. It helps to treat and prevent depression, I think a huge factor during the pandemic, as I already mentioned. It reduces the dementia risk, it triggers the production of new brain cells, it slows aging better than all the creams that you can buy for more than 100 euros or other currencies which don't do anything, because a lot of your skin is dealt with by genetic history, so DNA. And of course, a cream can work, but exercising seems to be even better. So I would say go for it. Reduces the risk of strokes and heart attacks, which is, of course, something we know already for years. And it has many other positive influences. I think that's in general for the population a good thing. Compression therapy, there it is. I think for us a very important topic. And what compression does not do, and I have said it, I think, over the years many times, even before I had seen all these studies and working with all these health professionals on a high level, but it can do something else. If we could do that, then we would be even richer, I think. But what we have to keep in mind, and this is still a slide from our ex-colleague that used to work at Medi as well, has left, unfortunately, to go and work as an independent consultant as well. And she wrote this great presentation on what the impact of the consensus paper is about compression in lipedema. And as we know, we cannot reduce fat, we cannot change the lifestyle of a patient with compression, but what we can do is look at the effects of compression nowadays in lipedema. And then the anti-inflammatory factor, the relief of complaints like pain, can be the motivation to sell compression, but also to advise compression. And that's the new role of compression therapy within the lipedema world. That takes a lot of educational work. And Annette, who wrote this slide, also focused on doctor-patient communication. Well, that's a very German approach. I think if we look at the rest of the world, not a lot of doctors are in first instance involved. So we need to educate also some GPs around the world, but also a lot of nurses, physiotherapists. And so the paramedic group that is in a lot of countries dealing with this problem. So a changed role, and that's something to get used to. But I think you can still sell compression in lipedema using those factors. So the new role of compression therapy, if we talk about that anti-inflammatory effect, then there is 2 studies. I'm not going to dig them out because we have short sessions today, so I have to move on, but you will get a handout of this presentation and you can read how this works. How does compression have a positive influence on inflammation? And that has to do with cytokines, but also some other roles. Please read those when you have time. Oh, I'm doing the colors. Then we have, of course, our products. I'm not going into detail because most of you know which products we have. But please, if you use stockings or adjustable compression wraps like Circade, then always keep in mind that the material plays an important role. So elastic versus non-elastic, and that's my favorite topic, of course, because I used to be on the crib of introducing Circade in the world, together with Sandra Shaw and her team in America. Of course, they were the first, but now we have a lot of copies. So don't think that in adjustable compression wraps there is not a difference in material. And we know by now how important it is to look at material. That's why we, our marketing has together with product management, developed this great overview on what our stockings can do for which patient. We're not allowed to say that the Medifan Cozy is especially for lipedema patients, because you cannot say that. It's not based on any science. But from experience, we can now say that the Medifan Cozy is the most flexible, the most easy to wear for those patients who have lipedema, who experience pain. Bruising is not an issue, as we know now, but they have to stay active. So a stocking that fits to that active lifestyle is definitely the Medifan Cozy. If there is obesity involved, then there is edema involved, completely different story. Then you can go also to the Medifan 550. And if it's all just at the very beginning, but they have discovered the patient has some kind of problems with lipedema, then the Mondi is of course also suitable. But motivation about why to use a stocking is very important. You have to know a few facts. When it comes to adjustable compression wraps, I told you already, don't let the competition tell you that they have a better product, because it's all about the elasticity in the material. And just as in stockings, we also have stretch issues in adjustable compression wraps. So ask them what the competition, what the material is, what kind of Velcro they are using, but most of all, also tell your customers to read the DFU. And you can never state in an adjustable compression wrap that it resembles a class 2, 3, or 4 stocking, because that's only for medical compression stockings. So you see some of the brands that are leading at the moment who have copied more or less Circade over the years, and some of them have made improvements. And I hope we can stay on top of that and still be the #1 in adjustable compression wraps. This is the Medi Lymphology Care Guide, where you all have access to in either your own language or in English, which can show you exactly which products we have for which patient group. Going to the last few steps of this new therapeutic approach house, I would say that the psychosocial therapy is just as important as compression. Those go hand in hand, because if a patient is depressed, they will not wear the stockings. If the patient is just down, it will not help either. So, well, Igor is coming in, I see, but it doesn't help motivating the patient to wear compression. So quality of life in lipedema is still a typical, I would say, issue that is not addressed everywhere. This is a study in which 120 patients were included, and they all had a high risk for obesity. More than 75% had a higher BMI than 30, and that's big. And the quality of life, there was no relation between quality of life and the severity of the problem. So the amount of obesity or weight gain did not play a role opposite quality of life. It has an influence. So the psychological approach should be strengthen psychological flexibility, get rid of illness beliefs, because illness beliefs have been created by all of us in the world of lipedema, because there's no one line in what should be done or what is best for the patients. Acceptance and coherence is necessary, so concordance we usually use instead of compliant. Cognitive behavior therapy, very helpful. They have to get out of that negative self-image to have a better life. So depression and appearance-related distress in functioning with lipedema, another paper, and that's from Poland, from Dudek. She has found her way in also in this working group in the European Lipedema Association, as it's called now, and she has done quite some studies where you see that most of the lipedema patients, in this case, the majority, has obesity. And this was done together with a Dutch patient who used to weigh 180 kilos and is now 68 kilos. An enormous story of how mindset can change that. So interesting to take into account. Also, Tobias himself did with his team research on the psychological issues due to obesity. And also here you see that patients with high BMIs had all obesity or at least were overweight. So it's a fact, I would say. Then the weight management, because that's then an important part of that therapeutic house. How do you do that? And that's not easy, because if you've seen Tobias, his lectures, then he will always say we're not talking about diet. And yet, even I got a mail from via Christopher today or yesterday about a question on diet in lipedema. Yeah, it's the wrong wording. We would like to say healthy lifestyle, because diet is something that you have to stop at a certain time and then go back to normal life. And it often works only for a short time. And what Tobias and the rest of the group also explains is then you get the yo-yo effect. So you come back to a fantastic weight, then you start eating normal again and you gain weight again. So the best way to deal with it is look at the problem itself and clear the relationship between weight and the lymphatic load. There is in the basics no lymphatic problem. It becomes a problem when obesity appears. We can discuss BMI, we're not going to do it, but we're talking mostly about waist-hip ratio, because in a classical lipedema patient, you see that the hips are often much larger than the upper body, and that's what we call a classic lipedema patient. And that's why those patients can be called lip algae or whatever it's going to be in the future. They don't have edema. Intake output is very important, even for me myself. I always listen to my colleague Bea Kutsi, is specialized in this calorie balance approach in lipedema. And she says, just keep it simple. Everything you put in your mouth has to be burned. So all the calories that you eat, you have to exchange into exercise. And that's the easiest way to understand. Diet is important, but don't call it diet. It's healthy lifestyle. Then there is a big hype, especially in the US, but now also in Europe, and that's the anti-inflammatory diet. It's called keto. Well, a lot of people are doing it right now, but also in keto diets, you have to keep in mind that you cannot do that for 2 weeks or 6 weeks. You have to do that for an enormous length of time to get the result. And then it works. But when you go back to a normal diet, your weight gain is also there again. So that's why keto diet definitely is a yes, and it works. But then for the future, you will have to change your lifestyle for good. Otherwise, it will come back. So there's a lot to be done in the world of dieting. But let's all call it something else. To show you that a keto diet works, here's Barbara again. There's 2 photos in which you can see the difference before and after. She's still not there. She wants to lose another 20 to 25 kilos. And she's on the right track. And it makes her feel so much better. She can run again with her little daughter. She can do work much better. She's less at home due to illnesses or pains, has less inflammation, so less erysipelas. So it's definitely working, but I'm curious to see how it will work in the long run when she goes back to a normal lifestyle. Or can you stick with keto diets the rest of your life? She's also on Instagram a lot with this no sugar recipes. It looks fantastic. I don't know what it tastes like, but it's also not easy to do. I know that Dr. Sarah Thomas, who was also speaking on Lymphology 365, is doing currently a keto research in lymphedema, so not in lipedema, but lymphedema. And there you see that the inflammation rates are going down rapidly. So it does do something, but don't think it's easy. And the last one, or last 2, is liposuction, which I'm not going to go in detail. We will have some other lectures from other specialists on this topic. But I chose some pictures that I know of myself, and this is from the UK. This is Claire and Claire Tickle, and she was one of the speakers in a Scottish event I was in, and she really had a fantastic result by changing her lifestyle. She had a normal food pattern, and she did in the end a liposuction. And I think this picture shows, the fantastic results. That means that she has to go into, at that time we didn't have COSI, so she went in 550. Now probably she will be in COSI in the UK, but you have to do a lot to keep this result. So compression is really, really important. This lady is from Dr. Bohne, who will also speak later this year. Dr. Bohne does a lot of liposuction in lipedema. And this is not a shocking case, I would say. A lot of females, especially in Northern Europe, have this shape of body. This is what he can make of it. But also here, it means that you have to do something. You know, it's all about exercising and healthy lifestyle. And another example from the Netherlands, of course an enormous result, but it's not that it ends there. So compression, but also exercising is definitely after liposuction. And I thought this was a nice picture, because you just cannot cut it off. You know, it's sucking it out, but then you have to step it up and have a lot of determination to keep the result. And then, of course, self-management is it's crystal clear, I would say. If you look at the therapeutical workup that the group has created, then you can see what has to be done. If the BMI is very high, you go to a dietitian or a bariatric surgery, also not without psychological help. If there's no lipedema, you have to look at what is the problem, or is it just the way you are built? As I said, a lot of women have bigger hips. And in the old days, they said, that's good, you have childbearing hips. Well, that's, of course, old-fashioned, but yeah, not everybody has lipedema, let's be honest about that. Education on food, caloric balance is important, weight control, etc. All the things that we know. The physical therapist plays an important role in helping to find the right exercises. So you don't have to do it alone. You can be coached by a physiotherapist. I wouldn't suggest to go to any old fitness school where they don't know the issue lipedema or obesity, how to deal with it, because then you need good advice. So then a registered physiotherapist is definitely better than just a regular sports school. Compression garments, very important that they can do that themselves, that they understand why they have to wear it, address the psychosocial problems, the negative self-image, and other treatment modalities or concepts are graded activity, which is related to the above mentioned activities, and self-management. Lipedema patients will have to self-manage in the end, because the cost of healthcare is going sky high, especially after this pandemic. And this is a group of people who can self-manage, but with coaching and motivational interviewing, get them back on their feet and show them that a positive attitude and some determination. And that doesn't have to mean that you can never fall back. Everybody falls back in life sometimes. And so does Barbara. She's now 6 kilos heavier again, or at least she was 2 weeks ago. But then together with her physiotherapist and her psychological coach, she will lose them again. But the further you get, the more difficult it becomes to lose weight. In conclusion, as stated in the consensus document and new guidelines around Europe, and then I found this text, like workout, nah, I get enough exercise jumping to conclusions and walking off disappointments. We had so many disappointments the last 2 years that's the same for lipedema patients. They have to endure a lot of disappointments. But in the end, there is now much more clear. It's not the end yet. We have to find out lots more about lipedema. But these are the main facts, and then I will close this session. The major symptoms of lipedema are uneven fat distribution and pain in the legs, In some cases, the upper arms can be involved too. Everybody has seen a lecture from Robert Damstra and others who explain that only 5% of all lipedema patients have lipedema in the arms. Other patients over 50, like myself, will develop some kind of skin changes in the upper arms. It will become looser, the tissue. It's not always lipedema. And that's also to do with illness belief. It's not in the belly, that's normal fat that everybody can develop, and only a small percentage has it in the arms. The disease is exclusively present in women. We know that for sure. If you say that a man has lipedema, then there's something else wrong. Then it's a hormonal disease, Madelung's disease, Derkum's disease, all terms that we hear a lot from America. Karen Herbst is really good in addressing those two. But we still don't know for sure whether that's related to lipedema. So right now, the statement is only in females. The vast majority of women with lipedema also suffer from obesity. Lipedema might affect your daily work and social life, your relationships, definitely your self-esteem, and your leisure activities. What lipedema does not, and take this home, it does not include fluid in the tissue of the legs and or the arms, also known as edema. That's related to obesity, not to the fat distribution. Cause of lymphedema is completely different. Then we're talking about flow problems, and then it's a different topic. It cannot worsen over time. However, if underlying obesity is allowed to progress, the lipedema can too. So again, if they increase, that's due to the obesity component. Complicated, but definitely the truth. The last slide, the difference approach between the European network and the United States network of Karen Herbst. We have come to an agreement to work together in the future, but still we have some different approaches, and that's due to cultural things, to reimbursement issues, and also some just scientific beliefs. In Europe, we believe in the biopsychosocial treatment. In America, it's much more biomedical. I think the Europeans in general tend to stay away from medicine more often than in the US, but that's an assumption. I think it will change also over there, but the access to medication is much easier in pharmacies, etc. Then in Europe, we call it a fat disorder from now on. And in the US, it's a loose connective tissue disease. Yeah, you can discuss about that. We will have to find a way in between, probably. Edema is not pathognomonic. That's a very difficult word, we say. And we say that it's definitely not present in those classic cases. In America, say there's always edema. Can loss of weight by diet and bariatric surgery can help, but in America, say the resistance towards weight reduction is still there, but it helps the patient a lot to move better. Even the lipedema goes down when you lose weight. So that's, again, different insights. Lipohypertrophy is localized, we say, in Europe. In America, they say it's generalized without pain and edema, and that's where they classify lipedema different than lipohypertrophy. Psychological effects are often pre-existent, and that has been proven by Dudek and the group and many other small studies. In the USA, psychological aspects are caused by lipedema. Questionable. I think we have some good scientific proof that most of these women had some psychological issues or negative self-image, and because they had those negative things in their life, they became obese before they discovered lipedema. We're in the phase of more hands-off, no MLT, because you cannot transport fat by massaging. If there is edema, then do something about obesity is in general the statement. And in America, they're still doing MLD for edema reduction, soft tissue mobilization, improving mobility. And yeah, it's a discussion point. We will need more research to say one or the other has the right opinion. So dynamic model and self-management and hands-off, it's a chronic disease. And in America, it's more that the health professional has to fix it. More medicalization and hands-on, if they can afford it, because that's another problem. I could go on for a while, but we planned on short sessions and I'm already talking too long. But let's talk about compression in lipedema, or lipalgie, which will be the name in the future if Tobias Burch gets his way, in a new way addressing pain and inflammation reduction. So you can still sell a good story. Do not hesitate to contact me or Valerie or David and the team. I would like to thank you for your attention. Valerie.
Els.
Are there any?
Here we are again. David is there too.
Yeah. Are there any questions?
Well, I have a question, and perhaps my question will start off other questions. Let's see. Because you said that lipedema cannot worsen.
Exactly.
So if it cannot worsen, couldn't that be used kind of as an argument in favor of liposuction? Because once I've had liposuction, the edema should be gone and not come back, in theory, right?
Well, in theory, there is no edema. There's only edema if you have obesity. So if you do a liposuction, then at that stage, they will remove all fluids, so and all the proteins, etc. But if you do not carry a healthy lifestyle, there might be an increase again of the buildup of fat in those fat cells. And then automatically the leptin goes up again, automatically your weight gain goes up. So it's like a circle in which you can stay if you do not change your lifestyle.
So in short, that after having had a liposuction, if there's again an increase of regular fat cells, so again an increase in obesity, this could trigger again the lipo cells, and we could have the whole issue again. Okay, good.
Because you have some kind of DNA that's still investigating at the Royal Marsden, together with the Hospital of Christiana Gordon, are investigating amongst 1,000 women. I think they had more than 1,000 now, if it's inheritable or whether it's another problem. And then you see that it is a DNA issue as well.
Okay, thank you so much. And actually, that's at least in the chat. There are no more questions, because also you really talked very thoroughly, but very interesting. It was, I think you had all the information inside of there. It was amazing. Thank you so much. Again, if there are any questions later on, you can come to us anytime. We will give this to you, so you will have this available for you. And yeah, that's it, I think, at the moment.
Oh, yeah, I see some hands clapping.
Hands clapping, yeah. I'm stopping the